Good morning, all of you. Um, uh, Now we are going to have a very important dermatological situation that is one of the vesicular diseases and gives a lot of difficulty when it really comes to you how to make a clinical diagnosis, how to make a definite diagnosis, and there are always a confusion at every stage. Some of the patients may have a little bit of uh, uh, the bulla spread or a little bit of less dense vesicle. So, and even sometimes the immunofluorescence may be a bit confusion. So, uh, because of this, we should have a clear-cut idea about what is bullous pemphigoid and how to make a clinical diagnosis and confirm it by various investigations. And we have a very good speaker. Um, she is from KMC Manipal. And KMC Manipal, if you remember, is the place where the immunofluorescence first started, apart from the um, institutes, all the Institute of Medical Science or PDI. KMC Manipal uh, has its own lab in dermatology of immunofluorescence. And when I asked uh, to give a talk on Bullous Pemphigoid, the speaker has very happily agreed. And I am sure you will enjoy her um, discussions. And after the discussion, if you have any doubt, you can directly talk to her. And I think I should not uh, I should not take away the time from the speaker. So I uh, give, give it to the speaker. Over to you, madam.
Thank you, sir. I hope my screen is
Yes,
visible.
yes, madam, visible,
Yeah,
madam.
yeah, it is. It is visible.
Good afternoon, everyone. First of all, I would like to thank Crichton, sir, for giving me this opportunity. And bullous pemphigoid is a vast topic, but I will try to cover important aspects. And if you have any doubts, I will be taking it towards the end of my talk. So let's begin. We will be discussing bullous pemphigoid along these headings. So we all know that bullous pemphigoid is an autoimmune blistering disorder where the split is at the subepidermal level. And it is a disorder basically affecting the elderly population with the average age of onset being 60 years. The incidence of bullous pemphigoid um, exponentially increases beyond 80 years, and below 75, women are affected more than men. However, after 75, the incidence increases in men. This is a disease which has genetic predisposition as well in the form of HLA-DQ7 and B7. So how does it present? Since the split is subepidermal and the roof of the blister is formed by a tough basement membrane, it results in large dense blisters, which could be either containing serous or hemorrhagic fluid. And usually these bulla rests on erythematous or urticarial background, or it could also rest on normal looking skin. And once the blisters rupture, it leaves behind erosions and crusting. And most of the time, bullous pemphigoid heals with only pigmentary changes, that is the hyperpigmentation without any scarring. Whenever we are examining a case of any autoimmune blistering condition, it is a must that we elicit these two important signs. One being the Nikolsky sign, where we apply a tangential pressure along the margin of a blister. It will be negative in case of bullous pemphigoid as there is no acantholysis. And one more sign that we must elicit is a bulla spread sign, where we first mark the margins of a blister and then we offer a unidirectional push. And in case of bullous pemphigoid and subepidermal blistering conditions, there will be a uniform extension of the blister beyond the marked margin. Whereas in case of pemphigus vulgaris and intraepidermal blistering conditions, the bulla is going to extend in a very angulated fashion beyond the marked margin because of acantholysis. So let us now understand the pathophysiology of bullous pemphigoid. To briefly tell about the pathophysiology, there are autoantibodies that are produced by autoreactive T lymphocytes activating the B cells to synthesize antibodies against the hemidesmosomal proteins, predominantly BP180, which is also called BP antigen 2 or collagen 17, and or BP230, which is the BP antigen 1. It is predominantly involving the Th2 pathway. It is associated with raised serum IgE levels, and it is a condition where there is where eosinophils play a predominant role. There will be increased number of eosinophils both in the lesion as well as in the peripheral blood, and elevated expression of type 2 cytokines and chemokines. We'll discuss this in much more detail in the coming slides. So, as we all understood, that there is production of autoantibodies against the hemidesmosomal proteins. The immunoglobulin is predominantly IgG1 in the acute phase and IgG4 and IgE in the chronic phase. So IgG1 brings about complement activation, and the end products of the complement form the membrane attack complex, which ultimately brings about disruption of the dermoepidermal junction and blister formation. Whereas in the chronic phase, where there is IgG4 and IgE autoantibodies involved, there will be activation of the Th2 pathway by the release of cytokines such as interleukin 4, 13, and 31. Note that interleukin 31 is the one which is responsible for pruritus. And all these cytokines are going to attract and activate various inflammatory cells into the skin, such as eosinophils, neutrophils, and mast cells, which are going to release various proteases, and ultimately it results in the blister formation. So this is a very beautiful diagram depicting the pathophysiology of bullous pemphigoid. So here we can see that there is autoreactive T cell which causes activation of the B cells, and the B cells are going to produce autoantibodies against the hemidesmosomal proteins. So in the acute phase, it is IgG1 which is predominantly produced, which causes activation of the complement, formation of membrane attack complex, and blister formation. And the end products of the complement cascade also can activate and attract the inflammatory cells such as neutrophils, mast cells, and eosinophils. In the chronic phase, IgG4 and IgE, they bring about internalization of the BP180 and its degradation, thereby causing a blister formation. And at the same time, it makes the keratinocytes release interleukin 6 and 8, which attract the inflammatory cells such as neutrophils, mast cells, and eosinophils. So if you notice clearly, the complement dependent and the complement independent pathways are not mutually exclusive, but they are interconnected, interlinked. And it forms this self-perpetuating cycle which continues and brings about the clinical manifestation in our patients. So to summarize whatever I have told you about the pathophysiology, the pathogenesis can be divided into complement dependent and complement independent. So complement dependent is mainly mediated by IgG1, the end products causing attraction of all these inflammatory cells which secrete proteases and blister formation. And this is a complement independent pathway where there is release of protein kinase C after binding of autoantibodies by IgG4 and IgE, internalization and degradation of BP180, release of interleukin 6 and 8, which ultimately attracts neutrophils, which secrete proteases, which disrupt the basement membrane zone. So let us understand the cytokine milieu in bullous pemphigoid. So we understood that it is a type 2 inflammatory response. So the cytokines will be also type 2 inflammatory mediated ones, which include interleukin 4, 5, 13, and 31. And the various chemokines that are involved are eotaxin 1, 3, monocyte chemoattractant protein 4, and thymus and activation regulated chemokine. So here we can see that BP230 and BP180, the localization in the dermoepidermal junction. So BP230 is present in the inner hemidesmosomal plaque, and BP180 is a transmembranous protein which attaches the BP230 to laminin 332. So the predominant epitope that is targeted in bullous pemphigoid is NC16A domain of BP180. Now let us move on to the clinical features. So the classical BP, bullous pemphigoid, presents with dense blisters on erythematous or urticated base. And once these lesions rupture, it leaves behind crusting and erosions. You can see here crusting and erosions, and all these blisters are resting on an erythematous background. The sites commonly involved are the flexures and the lower abdomen, and they are distributed symmetrically. Oral involvement is not very common. However, it can be seen in 10 to 30% of the patients. And it heals with this sort of pigmentary disturbances. You can see the salt and pepper pigmentation here. Milieu is something which we exclusively associate with epidermolysis bullosa acquisita. But we have seen a couple of cases of bullous pemphigoid which has healed with milia formation, which we will be discussing in the forthcoming slides. So Violent et al. Proposed this clinical criteria, which can be easily remembered as the 4 A's. That is the age above 70 years, absence of atrophic scars, absence of mucosal involvement, and absence of predominant bullous lesions on the head and neck. So 3 out of 4 should be present to call it as bullous pemphigoid. This criteria has a sensitivity of 90% and specificity of 83%. Remember that this clinical criteria holds good only for classical bullous pemphigoid and not for atypical forms. So this non-bullous variety, which is also called urticarial or eczematous pemphigoid, it constitutes nearly 20% of bullous pemphigoid patients, in which we get only eczematous urticarial plaques or prurigo-like lesions. And this sort of clinical picture can last months to years before progressing to bullous form, with the urticarial form progressing earlier to bullous form than the eczematous. And sometimes these patients need not develop bullae at all. The sites involved are typical of that of classical bullous pemphigoid. Coming to the mucosal involvement, as I mentioned earlier, it is seen in 10 to 30% of the cases. Buccal mucosa is the one which is commonly involved. Of course, we can also get involvement of the gingiva, as we can see here in the picture. And people with mucosal lesions and bullous pemphigoid tend to be younger, have more extensive disease, and require more intensive therapy. So mucosal involvement indicates that it is a severe disease. Genital involvement is not something which is commonly seen in adults. However, it is seen in 40% of pediatric cases with bullous pemphigoid. So these are the various clinical variants of bullous pemphigoid. So we have a localized bullous pemphigoid in the form of pretibial dyshydrosiform affecting the palms and soles. Nodular pemphigoid, wherein we get prurigo nodularis-like lesions. Pemphigoid vegetans involving the intertriginous areas. Erythrodermic bullous pemphigoid. Vesicular pemphigoid, in which we get predominantly vesicular lesions and no bullae. Then lichen planus pemphigoid is childhood and drug-induced bullous pemphigoid. So these are the various types which we discussed. Let us see the pictures. So this is a picture of vesicular bullous pemphigoid, wherein you can see the vesicles here. and a little bit of urticated lesions. This is a case of Bullous Pemphigoid with erythema multiforme sort of clinical picture. You can see the targetoid appearance. This is a pretibial variety of Bullous Pemphigoid. And this is the dyshydrosiform, wherein you're seeing large blisters and vesicles on the hands and soles. Coming to drug-induced Bullous Pemphigoid. So the drug-induced can be of two types, drug-associated or drug-triggered. What is the difference between these two? Drug-associated Bullous Pemphigoid, the clinical features usually subside on withdrawal of the culprit drug. Whereas in case of drug-triggered Bullous Pemphigoid, the clinical manifestations persist even after the culprit drug has been withdrawn. So the subsequent clinical course is the one which decides whether it is drug-associated or drug-triggered. So what are the common drugs that can induce Bullous Pemphigoid? The common ones are aldosterone antagonists and gliptins, that is the dipeptidyl peptidase 4 inhibitors. These are the commonly used anti-diabetics nowadays. And vildagliptin has a more tendency to trigger a Bullous Pemphigoid compared to linalogliptin. And of course, we have our immune checkpoint inhibitors such as pembrolizumab, which can induce Bullous Pemphigoid. How different is gliptin-induced Bullous Pemphigoid from classical Bullous Pemphigoid? It usually affects the younger age with fewer comorbidities, extensive blistering, and it has a very favorable response to treatment. Of course, drug-induced Bullous Pemphigoid should be treated according to the typical Bullous Pemphigoid protocols. Let us look at Bullous Pemphigoid in children. Though it is extremely rare, it can be seen. It can be of two types, infantile, where the mean age of onset is around 4 months, and the childhood type, where the onset is around 8 years. The most common trigger being the vaccination. So here we saw this child, an infant, who presented with these urticated lesions, blisters, and crusting, which occurred 3 weeks after he received pentavalent vaccine. So we went ahead and did immunofluorescence. So immunofluorescence revealed a linear IgG deposit along the basement membrane zone. We also did something called the serration pattern analysis. You can appreciate the beautiful N serration pattern here. We will be discussing more about the serration pattern analysis in the diagnosis when we discuss the diagnosis of Bullous Pemphigoid. So this child was managed with both topical and systemic steroids, and the steroids were tapered and the child was maintained on dapsone. And this was the follow-up picture after 2 years. And the prognosis of Bullous Pemphigoid in children is very good. So let us now move on to assessment of the disease activity. So we have clinician reported outcomes and patient reported outcomes, both of which should be considered in order to decide the therapeutic strategy for a particular patient. So in our setup, we usually do this BPDAI scoring to assess the disease severity. And this is a clinician reported outcome, which is followed even by S2K guidelines. So according to this scoring, you can read about it more in detail from this article. So it is classified into mild, moderate, and severe. And mild is when the score is below or equal to 90, moderate is ranging from 20 to 56, and severe is more than or equal to 57. So this has scoring for both activity as well as damage. And of course, we have abscess score. And these are the various patient-reported outcomes such as DLQI, ABQOL, and both these should be done whenever we are doing any study on Bullous Pemphigoid, and also to decide the treatment strategy. Coming to associated comorbidities, Bullous Pemphigoid as a disease is associated with a lot of comorbidities, more so the neurological disorders, the commonest being dementia. They can also have stroke, Parkinson's, multiple sclerosis, Alzheimer's, and even some psychiatric conditions such as schizophrenia and depression. And even these patients are more prone to develop thromboembolic events such as deep venous thrombosis and pulmonary embolism. So what is the link between bullous pemphigoid and neurological disorders? The neurological disorders are already present at the time of diagnosis of bullous pemphigoid, and around 30 to 60% of bullous pemphigoid patients have a coexisting neurological disorder. And these patients usually are positive for anti-BP 230 more than 180. So the neurological condition brings about a neuroinflammation, which basically causes exposure of the neuronal isoforms of BP 230 and 180 to the immune system, resulting in the production of autoantibody, which cross reacts with the skin isoforms of the same antigens. Those patients who have a coexisting neurological disorder, they tend to have intense tissue eosinophilic infiltrate, higher autoantibody levels, severe disease, worse prognosis, and higher mortality rates. Now let us move to the diagnosis. How do we diagnose bullous pemphigoid? Of course, first and foremost is histopathology. And from where do we take the biopsy? We take the biopsy from a recent intact blister. And if we are taking two samples for histopathology and DIF, it is advisable to take the specimen for DIF first, followed by histopathology, because we do not want any formalin contamination of the DIF specimen, which will render it unsuitable for reading. So what do we see on histopathology? We see a subepidermal bullae and the subepidermal bullae, and there will be a dermal infiltrate with the inflammatory cells. So predominantly it can be cell poor or cell rich based on the density of inflammatory cells in the dermis. So if the patient has blisters on urticated or erythematous skin, they usually tend to have a cell rich inflammatory infiltrate on biopsy. Whereas if it is on the normal looking skin, the blisters appearing on normal looking skin, they tend to have a cell poor sort of histopathological picture. In the early stages, when there is no subepidermal split, all we can see is that the eosinophils tend to marginate along the dermoepidermal junction. And in atypical cases, again, when there is no split, eosinophilic spongiosis is something which can give us a clue regarding the diagnosis. So direct immunofluorescence, it is the gold standard for diagnosis of bullous pemphigoid. The biopsy site is, of course, perilesional skin, 1 to 2 centimeters from the active bulla. And what do we see? We get a linear deposit of IgG and C3 along the basement membrane zone. Of course, in all subepidermal blistering conditions, we have to do our indirect immunofluorescence and ELISA. Why? Because all the subepidermal blistering conditions, except for linear IgA and dermatitis herpetiformis, will show a linear deposit of IgG and C3. So it is important that we distinguish one subepidermal blistering disorder from the other. And how do we go about doing it? We'll see it in the coming slides. So indirect is a must in order to differentiate between the subepidermal blistering disorders from one another. So the substrate used in case of indirect immunofluorescence is salt split normal human skin. So in case of bullous pemphigoid, we see a predominantly roof staining. So you can see the split here at the lamina lucida, and you can see the immune deposits nicely deposited along the roof of the split. But we can also get a combined pattern, that is roof and floor in some cases. So in 70%, it will be a roof staining pattern. However, in 30%, we get a combined roof and floor staining pattern. So this is a very simple flow chart basically which will help us in differentiating all the subepidermal disorders from one another. So on immunofluorescence, on DIF, if we get a granular IgA, then the diagnosis is straight away dermatitis herpetiformis. If we get a linear band along the BM set, then we have to see whether it is IgG-C3 or IgA. If it is IgA, the diagnosis is linear IgA disease. If it is IgG and C3 deposits, then we have to go ahead and do a salt split skin IAF, indirect immunofluorescence. If it shows a roof staining pattern then the diagnosis is bullous pemphigoid. If it shows a floor staining pattern, then the diagnosis could be one of these four. That is epidermolysis bullosa acquisita, laminin 332 type of MMP, anti-P200 pemphigoid, and bullous SLE. Now, how do we differentiate these from one another? That is by something called serration pattern analysis, wherein we take thinner sections and we observe the slide under higher magnification. So N serration is when the immune deposits are seen along the rootlets of the basal keratinocytes. And U serration is when they are seen in between the rootlets of the basal keratinocytes. So when we get an N serration pattern, it indicates it could be anti-P200 pemphigoid, which has a clinical picture almost resembling that of bullous pemphigoid, and laminin 332 type of MMP, where there is a predominant mucosal involvement, of course. Clinically, it is different. And U serration pattern is observed in epidermolysis bullosa acquisita and bullous SLE. So here we are seeing a N serration pattern, which is seen in bullous pemphigoid. This is a unique type of indirect immunofluorescence, which is called as a BIOCHIP-Mosaic 7, wherein a single slide has all these 6 antigens which are mounted on it. Okay, so this is a type of IAF where we put the patient's sera onto the slide, and in one go itself, it can detect autoantibodies directed against these 6 substrates. That is monkey esophagus, salt split skin, HEK cells transfected with desmoglein 3 and 1, BP 180 and 230. So this diagram shows the pattern also of the staining. So this is a very, very time-saving technique. So here you can see the immune deposits along the roof of the split in a BIOCHIP-Mosaic 7. So coming to ELISA, so we are moving in a stepwise manner. So first we dealt with histopathology, then DIF. DIF gives us a clue that it could be a subepidermal blistering condition. Then we go ahead and do IAF and ELISA to confirm our diagnosis and also to assess the severity of the disease. So ELISA can be monophasic or multivariant. Monophasic, in which we detect autoantibodies against BP 180 and 230, where the anti-BP 180 titers correlate with the disease activity. However, the commercial ELISA systems do not detect autoantibodies directed against the non-NC16A domain of BP 180 and the central domain of BP 230. What is multivariant ELISA? This allows simultaneous detection of circulating autoantibodies against several antigens. Several antigens such as BP 180, 230, desmoglein 1, 3, envoplakin, and collagen 7. So it's a single step procedure and it's a quite time-saving diagnostic procedure. So this is a simple flow chart which tells you how to go about diagnosing bullous pemphigoid. When it is a classical bullous presentation, then the clinical criteria with a positive DIF, roof staining on indirect and or positive BP ELISA clinches the diagnosis. When it is a non-bullous presentation, the positive DIF, roof staining on IF and or positive BP ELISA gives us the diagnosis. So this is a criteria which is criteria for diagnosis in case of atypical presentations of bullous pemphigoid, wherein the major criteria is DIF positivity and IF and BP ELISA positivity, and minor criteria is pruritus, classical histopathological changes, and polymorphic clinical presentation. So two major and one major criteria, or two major or one major plus two minor should be present to call it as bullous pemphigoid. When the DIF is negative, but there is a strong clinical suspicion of bullous pemphigoid, we need to repeat DIF. And if repeat DIF is also negative, then the suggestive clinical picture, histopathological finding, and roof staining IAF and positive BP ELISA will give you a clue. So coming to mortality and morbidity, bullous pemphigoid is a disease which is associated with a lot of morbidity rather than mortality. So the morbidities, because it is commonly seen in advanced age, and advanced age itself is associated with a lot of morbidity. The patient will have a lot of comorbidities, which we saw earlier, such as the neurological disease, the psychiatric disorder. Sometimes they can be associated with various metabolic disturbances, such as diabetes. So the mortality in bullous pemphigoid is not due to the disease per se, but because of the infection, and it could be because of the adverse effects due to the treatment, as they are put on long-term systemic steroids and immunosuppressive agents. So now we'll move on to the treatment. Treatment can be broadly classified into topical, systemic, and supportive. So what are our objectives of treatment? We have to treat the current disease, reduce the itch, prevent and reduce the recurrence of lesions, improve the quality of life of our patients, and limit the adverse effects associated with the treatment. So coming to topical treatment, according to the S2K guidelines, clobetasol propionate 0.05%, which is a super potent corticosteroid, is the treatment of choice. So we decide whether it is a mild to moderate disease, which we saw earlier, that is the BPDA score will tell us whether it is mild, moderate, when the scoring is below 56. And also when there are less than 10 new blisters per day and very few inflammatory lesions, we call it as a mild to moderate disease, wherein they have to apply around 20 to 30 grams of the tube per day. If it's a severe disease with a BPDAI score of above 57 and more than 10 blisters appearing per day, then they have to apply a higher quantity of the topical preparation, that is around 30 to 40 grams per day. So once CDA is achieved, CDA is control of disease activity. Once that is achieved, we maintain the treatment for another 2 weeks, and then we start to taper over a period of 4 to 8 months. So this is the one which is proposed by S2K. Of course, in a country like India, where the patient load is too much and nursing care is not as in case of a Western scenario, this is not very, very practical. Coming to systemic treatment, the drug of choice is, of course, systemic corticosteroids, the dose being 0.5 mg per kg per day of prednisolone. If they respond to this dose itself, then we wait until the patient has achieved control of disease activity. What do we mean by control of disease activity? That the patient stops to get any new lesions and the established lesions show signs of healing. Then we start to taper the steroid once CDA is achieved over a period of 4 to 6 months. If in case the disease relapses during tapering, go back to the previous effective dose. So the total duration of treatment is around 9 to 12 months. This is something which we have to counsel the patient. Otherwise, the patient might stop the treatment once they stop getting the new lesions and end up with a relapse. So if it does not respond to 0.5 mg per kg per day of prednisolone in 1 to 3 weeks, then either we can increase the dose to 0.75 mg or we can add a topical corticosteroid along with 0.5 mg per kg. Coming to adjuvant therapy. So adjuvant therapy, the choice depends on the availability, affordability of the patient, disease severity, contraindications, if any. And the various adjuvant therapy that are available are doxycycline nicotinamide combination, dapsone, and various immunosuppressive agents such as azathioprine, mycophenolate, and methotrexate. And when do we choose these adjuvant immunosuppressive agents in bullous pemphigoid? When there is a contraindication to oral corticosteroids, and we cannot continue oral corticosteroids for a very long duration of time. When the patient at the time of presentation itself has a lot of comorbidities such as diabetes, hypertension, osteoporosis, then we have to taper steroids quickly, and we need to add on an adjuvant therapy to maintain them in remission. When the disease is quite severe and we are certain that one agent won't be sufficient to bring the disease under control. And of course, in a relapsing and a recalcitrant disease. So this was our patient who had extensive disease, and he was not responding to the minute we tapered steroid would again end up with a relapse. So we tried a lot of adjuvant therapy in him, such as dapsone, azathioprine, cyclophosphamide. Coming to biologics in bullous pemphigoid. So there are a lot of biologic agents which are currently being used in bullous pemphigoid. We have our rituximab, which is a CD20 blocker. It is not as effective as in pemphigus, in bullous pemphigoid. It has a higher recurrence rate of around 30 to 40%. And of course, we have IgE blocker, omalizumab, and interleukin 4 receptor alpha blocker, which is the dupilumab. These two have shown a pretty good efficacy in bullous pemphigoid, around 60 to 70%, with a lower risk of recurrence. And we have interleukin 5 blockers, such as vipolizumab, breslizumab, interleukin 5 receptor blockers, such as benralizumab, and interleukin 31 blockers, such as the nemolizumab. So we need to basically do an extensive workup of all our patients before we put them on systemic corticosteroids, immunosuppressive agents, or biologics for that matter. So we need a complete blood count, liver and renal function test, chest X-ray to rule out pulmonary tuberculosis, viral serology, G6PD if you are planning to start the patient on dapsone, TPMT for azathioprine, serum IgA levels if we are contemplating IVIG, and DEXA scan, ocular examination, ECG and echo before we start the patient on rituximab. So all these are a must. So this is as per S2K guidelines, which gives a more or less a step ladder approach, what to do if the disease is mild to moderate. Then the first choice in localized BP is only topical corticosteroids, whereas in non-localized, we can either go for topical or oral corticosteroids. The second choice being doxycycline and dapsone. In case of severe bullous pemphigoid, super potent topical steroids, greater quantity, that is 30 to 40 grams. Oral corticosteroids, 0.5 mg. If they don't respond, then increase to 0.75, which we had earlier discussed. And in corticosteroid dependent or relapsing, we have to use adjuvants such as methotrexate, azathioprine, or mycophenolate. And in people who have a very poor general condition with multiple comorbidities, we have to consider doxycycline, dapsone, or omalizumab. Especially if the patient has multiple comorbidities, malignancies, then omalizumab works safer in such individuals. In case of treatment recalcitrant BP, that is, which is resistant to even a higher dose of systemic steroid, that is 0.75, then we have to combine it with immunosuppressant, or we can consider other options such as the biologics. Supportive treatment is equally important as much as the specific treatment. So if the patient has extensive erosions, we have to go ahead with the non-adherent paraffin dressings for these patients. Potassium permanganate soaks and baths are quite helpful. And if the patient has a very large blister, we can drain the blisters but keep the roof intact so that it acts as a natural biological dressing. Prophylactic antibiotics can be given in order to prevent superadded infection. And of course, we have to give them calcium and supplements and bisphosphonates if they are on long-term systemic steroids. Coming to monitoring and course of the disease. So on follow-up, what are the things that we have to look into? We have to do a thorough clinical examination, look for whether the old lesions are healing, whether the patient is getting any new lesions, record their blood pressure and weight. We have to look for features of hypothalamic pituitary axis suppression. Ocular examination should be done in order to rule out the possibility of cataract if they're on long-term systemic steroids. What are the blood investigations that we have to advise? A complete hemogram, liver and renal function test. If the patient is on immunosuppressive agents, including systemic steroids. Serum glucose to rule out steroid-induced diabetes. An anti-BP 180 ELISA should be monitored at baseline, day 60 and day 150, as it correlates with the disease activity. Coming to the course of the disease. So this is a disease which lasts from a few months to 10 years. And mortality, as we discussed, it is mainly because of the age-related causes and treatment complications rather than the disease per se. The treatment will last around 9 to 12 months, and it is discontinued once the patient is in remission for 1 to 6 months under minimal therapy. And what do I mean by minimal therapy? That is zero point 0.1 mg per kg per day of prednisolone equivalent, or topical corticosteroids 10 gram per week, and immunosuppressive agents, the minimum dose. So to conclude, Bullous pemphigoid is the most prevalent autoimmune blistering disease in the elderly, which manifests with intense pruritus, urticarial or eczematous lesions, dense blisters, and erosions, predominantly affecting the trunk and flexures. In 20%, it can present as a non-bullous form. The incidence of BP is increasing because of increased awareness about the atypical forms, and we are sending investigations such as immunofluorescence and DIF in the atypical ones. Increase in dementia and other neurological disorders in the elderly, increase in the usage of gliptins and immune checkpoint inhibitors which trigger bullous pemphigoid. And treatment itself is quite challenging considering the unique health concerns of elderly individuals, high burden of comorbidities, polypharmacy risks, and age-related changes in drug metabolism, and heightened risks associated with immune suppression. Now let us quickly go through some of the interesting cases and the common mimickers of bullous pemphigoid. So this was a 45-year-old lady who presented to us with the lesions, urticated and eczematous lesions, and you can see blisters here on an urticated background. So we did immunofluorescence, and she was found to have a linear deposit of IgG and C3 along the BMZ, and IF showed a roof staining pattern, and BP 180 ELISA was positive. What I'm trying to highlight through this case is we can get head and neck facial involvement even in bullous pemphigoid, though it is mentioned in the clinical criteria as that it is absent. So we do get to see such unique forms of bullous pemphigoid. So this was a patient who presented to us with extensive blistering on the trunk, and you can see the beautiful string of pearl appearance here. So we went ahead and did the immunofluorescence, and here you're seeing that there is a linear deposit of IgG and C3 along the BMZ. And here we are seeing that this is a IAF specimen, which is showing floor staining on IAF. And this is the serration pattern analysis, which is showing N-serrated pattern. And we went ahead and did immunoblotting. That is, the patient sera was added to the dermal extract containing anti-P200 antigen and anti-gamma 1. And this was a case of anti-P200 pemphigoid. So here you're seeing these blisters arranged in an annular fashion, the string of pearl appearance, which we saw earlier, on an urticated base. And here we are seeing linear deposits of IgA on DIF. So this is a case of linear IgA disease. So what I want to highlight here is, just like in the previous case, what you saw, it was a case of anti-P200 pemphigoid with a string of pearl appearance. So string of pearl is something which is not exclusively seen in linear IgA disease. It can be seen in other conditions also, such as anti-P200, and even in case of bullous pemphigoid. So this was a patient of bullous pemphigoid, and here you can see the arrangement. There is a string of pearls and on an urticated background. So here also you can appreciate multiple vesicles arranged in an annular fashion. So this was another case where they presented with these vesicles and bullae. Some were looking hemorrhagic. So we went and did the DIF and IIF. DIF revealed IgG and C3 along BMZ. This is a picture of indirect immunofluorescence, wherein you're seeing that there is a floor staining So this is the yellow dot indicates the split, and the immune deposits are seen along the floor of the split. And we went ahead and did the serration pattern analysis, which is showing the beautiful U serration pattern here. And we also did, we put the patient's cilia on recessive dystrophic EB skin, which lacked collagen 7. So there was no staining seen here, which indicates this is a case of epidermolysis bullosa acquisita. This is another interesting case of bullous pemphigoid, wherein we are seeing that it is resolving with milia formation. So milia is something which we exclusively associate with epidermolysis bullosa acquisita, but it is not specific to it. You can also get it in bullous pemphigoid. So with this, we conclude. If you have any doubts, I can take it now.
Is there any questions, means you can directly ask to ma'am. Okay. Okay, madam. Since there is no questions, now it is a time for vote of thanks, madam. So first of all, East West Pharma extend its heartful gratitude to the esteemed speaker, Dr. Varsha Shetty ma'am, for sharing her valuable clinical experience on Bullous Pemphigoid for the benefit of postgraduates today. The lecture was extremely lucid, insightful, and highly beneficial for our PGs as well as aspiring dermatologists. We also express our sincere appreciation to our Honorable Course Director, Dr. Kedden sir, who has been consistently successfully conducting this webinar series for the past 3 years, featuring renowned professors across the country. Once again, we congratulate the quiz winners for their excellent performance. The edited version of this today's session will be uploaded shortly on our YouTube channel. We request you to kindly visit our channel and explore the previous conducted programs as well. And once again, we are heartfully thanking from our East West Pharma, those who are all participate as speakers as well as course directors. Thank you so much, ma'am.
Thank you.
Thank you, ma'am.